Hello and welcome. You're watching Coronavirus Facts versus Myths. I'm Rishika Barua. On the show today, we look at the new controversy on dosing gap. We'll also tell you what is this new Delta Plus variant. And we'll ask the million-dollar question on whether vaccines will work with this 12 to 16-week gap. And will they work against these new virus mutations? But our top story. A report in Reuters today says that the Indian scientists, a section of Indian scientists, didn't back this 12 to 16-week dosing gap for Covishield. The report even quotes members of the National Technical Advisory Group on Immunization who say that they advised an 8 to 12-week gap, but the government went ahead with 12 to 16 weeks anyway. Now, the government has clarified. The health minister has tweeted. There's a very robust clarification, justification that's been issued by the government, where the government claims that there's no dissent among the technical advisory group members regarding this decision and that the decision was based on scientific evidence. But where does the scientific community, where do doctors in India really stand on this issue? We have Dr. A.K. Singh with us. He's a senior consultant endocrinologist, GD Hospital and Diabetes Institute, joining us from Kolkata. And he says that he's written to the health minister questioning this gap. Dr. Singh, the 12-week gap for Covishield was scientific according to you in the earlier part of January to April, but not anymore. Why?
Well, so in the initial phase, we had the data from the UK, the data from with Covishield, which generated from the Oxford. That data suggested that if you increase the gap from 6 to 12 weeks, the effectiveness of vaccine also increases. So you have seen the ranges of Covishield effectiveness from 62 to 72%. That is depending upon the gaps of vaccination. So in the initial part, when the vaccination started in India for the healthcare worker, I was one of the first to receive the vaccine on 16 January. At that point of time, I wrote to the health minister that why not you increase the gap of Covishield to 12 weeks, because the data suggests that effectiveness of vaccine at 12 weeks is larger than if you inject at 4 to 6 weeks. At that point of time, nobody responded, and in fact, I had to take my second dose exactly on 4th week, that is 28 days. Despite that, we shouted basically at the top of voice that please increase the gap so that the more healthcare workers should get the first dose. Now, when the Delta variant has come into the effect, and then increasing the gap from initial 4 to 6 weeks, from 12 weeks now, doesn't look, justified, because we don't have any evidence at the moment that suggests that if you increase the gap, your chance of, getting less infections with COVID is less. So we don't have any evidence of 12 weeks increment around the Delta variant time.
Right.
That's
the government though claims, and Dr. Singh, I have to put this out as well, and we will put out, that's the government version that we're putting out on our screens. The government says that they've taken a decision based on scientific evidence. How does this vaccine dosing gap now work against the Delta variant? Do you think India needs to go back to 8 to 12 weeks? Because after India extended the gap to 12 to 16 weeks, the UK actually reversed it for a certain section of their population.
Absolutely. So this is exactly what I was trailing, that in the initial part during the wilder variety initial strain of SARS-CoV-2, the 12 weeks gap was justified. But unfortunately, at that point of time, we were supposed to take vaccine at 4 to 6 weeks interval. But moment UK, decided to give it in a lesser gap period from 4 to 6 weeks, knowing that Delta variant and vaccine might not be effective in Delta variant, I don't understand why government of India has increased it to 12 weeks. Where is the evidence? Please show us the evidence.
Okay, but now you're saying that we did it on the basis of data that was available in the UK. You're saying the data is redundant. What does India need to currently do? What needs to be the rethink? What's your recommendation?
So what is being claimed here, the UK data is not now on the 12 weeks on Delta variant.
Okay.
This data is based on 4 to 6 weeks, of gap. So where from the 12 week is justified? I don't understand this logic.
All right. So more questions than answers really at the moment, but there are several questions about this dosing regimen that have been raised. Is the Indian government going to take a rethink? Will we be re-looking at new data that's coming in even from the UK? We'll continue to ask several of those questions. Thanks, Dr. Singh, for joining us. I know you've written to the Health Minister. You tweeted about it as well. We'll wait to see if you get a reply as well. Well, on to the other big focus for us on the show today, the Delta variant of COVID-19, which is, largely behind the second wave, the variant that we're all so worried about, has now evolved into a Delta Plus or a AY1 variant. Now, it is characterized by the K417N mutation. What is this? Well, this is a mutation in the spike protein of the coronavirus that basically causes the COVID-19 disease, and this variation essentially allows it to enter the human cell. Now, scientists are saying that there's no real cause of concern just yet. But could this new Delta Plus variant have an immune escape tendency, and will it work against the monoclonal antibody treatment? Those are the two big questions that we're looking to answer. Dr. Sarman Singh, the Director of All India Institute of Medical Sciences, Bhopal, also a senior virologist, joins us. We also have Dr. Sushila Kataria, Director and Head of Internal Medicine at Medanta Medicity. Thanks, doctors, for being with us. Dr. Singh, first to you. What more can you tell us about Delta Plus?
Yeah, Rishikaji, thank you very much. This is true that the mutations are very common phenomena, and particularly in RNA viruses. So the mutations are happening. Earlier there was B1617.3, which got redundant, and it is now disappeared from the circulation because it is not beneficial to the virus pathogenicity, and therefore now we have 617.2 and 2.1 again.
Yes.
So these are the beta and even the gamma, which is new names which are given. Some of the they have, this variant has about 5 mutations, and the most important mutations, they are also found not only in this. That's why it is called in gamma as well as in beta also, and therefore it is known as plus. And the new name probably maybe in coming weeks or so might be given to this variant, but as of now this is only given the plus. So it has some of the mutations which are very, very crucial to immune escape. That is the concern. But the good thing is that so far this Delta Plus and even the Gamma, which is reported from Pune laboratory, these are very few numbers. But another program in your channel only a few days back, I was saying that we cannot be complacent that we are having only few cases. You never know that from 2 to 20 and 20 to 2000 when it will become, because these are highly virulent and infectious strains of the virus.
Yes. Dr. Sushila Kataria, very specifically a concern regarding the Delta Plus is whether the monoclonal antibody treatment touted to be a game changer in India, will it work against the Delta Plus? These are questions that are already being raised. What more do we know about it?
So, as we know that there is a new mutation acquired by the Delta variant, which is called a Delta Plus variant. Whether this variant will become a variant of concern, that will depend upon the time. So, if it becomes a variant of concern, that means it becomes more infectious or becomes more severe in course, then we need to be concerned about this. Whether monoclonal antibodies will be totally redundant, I don't think so. But if it is less effective, then monoclonal antibodies are made in the lab by DNA recombinant technology. And it is very easy to add one more component to this mixture of monoclonal antibodies. At this stage, we should not be worried. But yes, we should correlate, do more and more molecular sequence. And we should correlate these sequences with the clinical data of the patient. Meaning thereby, all those who had this kind of infection, were they more severe? Was it more spreading into their community? So these are the things we need to answer with time. About monoclonal antibodies being redundant, we should not worry. I don't think that would be. And if so, there is a solution to that.
Right. Dr. Singh, if I can come back to you at the moment, what lessons have we learned from the Delta variant that we can now apply to the Delta Plus? We learned late in the day perhaps that the Delta variant was more transmissible than the Alpha variant. It's largely caused the second surge of COVID-19 in India. What lessons have we learned that we can now apply to Delta Plus?
Rishikaji, unfortunately, we are not learning lessons. That is, bitter truth. because we need to do the lot of sequencing on daily basis, animal studies. So I think the research component is quite weak in India, and that is probably we need to strengthen our research. And we know that in December itself it was a quite prevalent the Delta virus, and February it reached to the we did some sequencing and we found that interiors of the Madhya Pradesh it reached in February first week.
Are we doing enough? Are we doing enough genome sequencing, Dr. Singh, to understand more about the Delta Plus?
Yeah, we need to do more.
Okay.
We are doing, but it is very less number. So we need to do huge number of the samples, and definitely that will direct our prevalence and surveys. Repeated surveys are very, very important.
Okay, so more data is needed, more surveillance is needed. The Delta Plus, as we know, is here, but more needs to be studied about it. Thank you very much for joining us on this extremely important conversation, new cause of concern. But the million-dollar question, as these new mutations and variants are detected, the question that's on everyone's mind is whether the vaccines will work and for how long will the vaccines give us protection. Well, Dr. Saad Omar, the director of the Yale Institute of Global Health, joins us, and we asked him some very critical questions about vaccines and whether they'll work. Dr. Omar, will the vaccine work against this new Delta Plus variant, and God knows how many more variants they may be in the future? And how will we know if our vaccines are working against new emerging variants?
So there are a few ways of looking at vaccine effectiveness and whether the vaccines that are available work against these emerging variants. First is an immunological evaluation. So look at the immune response, the neutralizing antibodies, etc. And try to gauge, compared to other variants, how are these vaccines performing. The second one, which is a more short way of looking at it, is field effectiveness, meaning people who are getting the vaccines versus who are not getting the vaccines, how many of them are getting sick with this virus, and to what extent, to severe versus non-severe. So right now, the data suggests that a lot of the vaccines that are out there are holding up against the new variants. For example, the UK posted some really interesting data last night, their time, and they suggest that the AstraZeneca vaccine, not just Pfizer vaccine, seems to be holding up against the Delta variant.
Yes.
The big picture worry is that so far, a lot of these vaccines, not every vaccine has been evaluated against the variants. A lot of these vaccines are being, useful and are holding up against these variants.
Right.
We are concerned about the future. If this fire continues to burn, newer and newer variants continue to emerge,
yes,
there may be a time where there's a chink in our armor.
But that's the question. How will we know when vaccines need to be tweaked or when we need booster shots to respond to new variants?
I think, time will tell. So I think there will be a few months before that decision is made, at least a few months before this decision is made. And from my perspective, I don't think it's a foregone conclusion. The likelihood of a booster or a sort of an additional dose to combat these variants is there and has increased, but it's not a foregone conclusion. So from my perspective, right now, the most reasonable, rational strategy is to vaccinate as many people as possible,
right,
with the current vaccines, and as quickly as possible, so that the probability of these newer variants emerging goes down substantially.
All right. So you're saying we need to essentially stop the chain of transmission. But the other big headline for us here in India is now more doubts about the Covishield dosing gap. 12 to 16 week gap is being questioned. Do you think, given the new data that's available, India needs a rethink?
No, I think 12 to 16 week, given the consideration of some of the other data that says that for the AstraZeneca or the Serum Institute of India vaccine, essentially the same vaccine, you have a somewhat better efficacy and effectiveness with this kind of an ideal gap. So I think that is rational, and I think it's very rational to stay with that. But again, that gap gives you the ability to deploy the vaccine to more people, which is also good. But who gets these additional doses also matters. So if other people in the high-risk group are getting it, that is, again, in line with a drastic mortality prevention strategy.
Right.
But if you are using that to again sort of dilute the impact of these vaccines to the high-risk group, then that's a little bit problematic. So I think that the gap makes sense at this point that you have between the doses, but who gets these vaccines first? Eventually, everyone should get it, but who gets it first at this point is important.
All right. So dosing gap you're saying is okay, but priority considerations need to be made. Thanks so much, Dr. Omar. Those are important questions that you've answered for us on a very important day. Thanks for joining us. We're going to slip into a very short break at this moment, but Dr. Sushila Kataria will be live with us on the other side, and she'll answer all your questions on the COVID-19 vaccine. Stay with us. Welcome back to our special campaign, Vaccinate India, in partnership with Google. We're discussing questions you'll have about the COVID-19 vaccine. Dr. Sushila Kataria, Director and Head of Internal Medicine Department of Medanta Medicity, is with us. Thanks so much for being with us. One of the most commonly Googled questions, Dr. Kataria, is on the effectiveness of the COVID-19 vaccine. Given the fact that there are new emerging variant strains that are, being discussed, alpha, beta, gamma, delta, what more can you tell us about vaccine effectiveness?
See, the only and the most effective way, I would say, the most effective way of preventing any infection is vaccine. And this is completely true for COVID-19. There are a number of vaccines, and new are more likely to come in 6 months' time. We'll see a lot of happening on the vaccine front. But all those vaccines which are available currently in India, be it Covaxin, Covishield, Sputnik, they have come through a scientific process. Their safety and their efficacy is not to be questioned. The idea of vaccine is to prevent infection and to prevent severe infection if it is not able to prevent the infection altogether. So there is no question on the safety and efficacy of these vaccines. Any vaccine which is more than 50% effective is a good vaccine. And all these vaccines fulfill that criteria very much by a good margin. So I say all the vaccines are effective. New developments are going to happen. But the most important thing is for everybody to get vaccinated. But the larger number of population we can vaccinate, we can eliminate or reduce the impact of COVID-19.
Right. But there are concerns about breakthrough infections. There are immune escape mechanisms of the new variants that are talked about. How effective will our vaccines be against that?
So currently, whatever mutations we have, these vaccines are effective. So there is a little genetic change in the virus, which happens with all the viruses. Unless there is a total genetics shift is there, the virus changes its structure altogether. That can alter a vaccine totally useless. But by and large, the mutations reduce the efficacy of vaccine by 5 to 10% maximum. Right. So currently available vaccines and the currently present mutations are well covered.
Is it safe, therefore, to believe that you could potentially get COVID-19 even after you've been vaccinated, especially if you've just got a single shot, but it can still guarantee you protection against severe disease or protection from hospitalization?
So effective vaccination will only be called once you have received both of the doses and 2 weeks duration.
Right.
In spite of having 2 doses, the infection can happen. But it will be of a milder intensity. If you are supposed to have a moderate infection, it will be mild.
Right.
If you are supposed to have a severe infection, it will be moderate.
Right.
If you are supposed to have a critical infection, it will be severe. So it has done its work. Sometimes no vaccine, we want their vaccines to be 100% effective, but mostly vaccines are between 50 to 96% of efficacy. So there will be some individuals who will have breakthrough infections. That's why even after vaccination, it is important to have a proper masking habit.
All right, very important. You can't let your mask down even if you've got both shots of the vaccine, because you could potentially still get infected. But then, when we're talking about reduction in severity of disease due to vaccination, the next big question, therefore, is self-care during COVID. If you get infected, you have a mild infection, what are the cardinal rules for self-care, Dr. Kataria?
First and foremost is to be aware of your symptoms so that one gets tested immediately. So early testing and then isolation prevents the infection from propagating to other individuals. Then for your own care, isolate in a proper way is most important, in an honest way. Then connect with the doctors to have a proper care. It is not important to have antibiotics and a lot of antiviral medication when somebody is having only a mild infection.
Right.
But a good rest, a good hydration, and a good symptomatic control. There may be some individuals which are into high risk group. Now we have these emergency use authorization for monoclonal antibodies. And early the use, the better it is for those individuals. So it is important to be aware of your symptoms, get treated and isolate for others. Take care of yourself for yourself.
Very interesting that you talk about monoclonal antibodies. Who is eligible?
So monoclonal antibodies, as per the DCGI approval, anybody who's above the age of 65 years,
Okay.
anybody who's diabetic, anybody who's morbidly obese, meaning BMI more than 35, anybody who has a kidney disease or a liver disease, and people above the age of 55, if they have one of these conditions like hypertension or maybe coronary artery disease or a COPD.
Right.
Even children who are above the age of, between the age of 12 to 17 with any heart disease, if they
Right.
have any lung condition, neurological condition, they can also be benefited.
All right. Well, thanks so much, Dr. Kataria. Those are important clarifications that you've given us. Thanks for joining us.
Thank you very much.